Did you know that medical care has very little to do with making you healthy? In this video, I'm going to explain not only what makes individuals healthy, but also what makes societies healthy. My goal today is to show you how over the last couple of decades, we have laid the foundation to transfer the responsibility of keeping you healthy from the government to the private medical industrial insurance complex. My name is Sudeep Bansal. I'm a primary care physician in Connecticut and I run my own practice. In the past, I've held several administrative roles in health management, and I have degrees in health informatics and population health. My past and ongoing experiences with healthcare gives me a unique opportunity to understand why healthcare is in such a big mess. Let's get started. So let's start by looking at the definition of health itself. The best definition of health comes from the World Health Organization, and they define health as a state of complete mental, physical, and social well-being, and not just merely the absence of disease or infirmity. What this definition is highlighting is that there's a lot more to being healthy than just not being sick. In one sense, being healthy gives the individual, that is you, the capacity to live life to the fullest. For example, if you don't have any disease, but are constantly worried about putting food on the table at night, it will impact your mental health, which will eventually spill over to your physical health and make you sick. Now, once we define health, the next question becomes, what determines a health? And the first determinant is socioeconomic environment. This includes things such as job, education, income, family, and community. There's plenty of data to support that people in the higher socioeconomic class, they enjoy much better health than those in lower socioeconomic class. The next determinant is our physical environment. Exposure to pollution and carcinogens are the obvious example here. But this also includes things such as healthy food, housing, clean water, transportation, and also sidewalks, bike paths, and parks to allow people to get some physical activity. And the last one is our individual characteristics and behaviors. This includes not only smoking, alcohol, and drug use, but also our genes. Now, in my opinion, individual behavior is heavily influenced by socioeconomic and environmental determinants. If a person grows up in an area where they don't have stable housing and access to good schools, but they have easy access to cigarette and liquor shops, they are much more likely to develop smoking and alcohol dependence in the future. Also, if everyone around you is engaged in risky behavior, it makes it much harder to quit those harmful behaviors as you don't have good role models. Robert Woods Johnson Foundation has an excellent quote on health. Health begins where you live, work, and play. Some of you may have seen the diagram floating around on the internet that puts a percentage that each health determinant affects a health. This diagram shows that socioeconomic determinants affect approximately 40% of health. Again, this includes things such as income, job, family, and community. Our physical environment is approximately 10%. Our behavior is approximately 30%, while medical care is only about 20%. Now, this diagram was published by the Institute for Clinical Systems Improvement. Their website doesn't work anymore, and I was unable to find the original article and how the authors came up with these numbers. But even in the best case scenario, medical care is only responsible for 20% of your health. So let's talk about the medical system. Our medical system is very good at treating acute and chronic illnesses, and to some extent screening for chronic disease. But we are not very good at keeping you healthy. You may be wondering then, what about the annual physical? Surely getting an annual physical or annual checkup helps me stay healthy. Let's talk about an annual physical. There's actually no good data that an annual physical improves health. The value of a physical exam is that you have a relationship with a doctor that you know and trust, to someone you can turn to if you fall sick. And to some degree, annual physicals may help in identifying risk factors early on that can impact your health later. However, it is very hard for the medical system to modify risk factors just based on education. Most modifiable risk factors are heavily dependent on socioeconomic and environmental determinants. Again, smoking cessation is harder in an environment where everyone smokes, compared to when everyone around you is prodding you to quit smoking, and also when regulations make it a lot harder to light a cigarette in public spaces. It is harder to exercise without access to parks, gym, and more importantly, time. Let's take the example of a single mother who's working 2 jobs to make ends meet and also taking care of kids. She does not have the time to exercise. She's in survival mode. Without addressing socioeconomic and physical environmental factors, it is very hard to change behavior. There are also other challenges when measuring the role of annual physicals in keeping people healthy. People who are health conscious and have higher education are much more likely to go for an annual physical. On the other hand, people in lower socioeconomic status may lack insurance coverage, transportation, or the ability to take time off work. Educating someone about exercise, smoking cessation, or other healthy habits is not going to help if they are preoccupied by how they are going to pay their next rent. By the way, if you're watching on YouTube, please like and subscribe. This helps me find a wider audience and spread the message. If you're watching on Substack and you've not subscribed, please consider becoming a paid member. It helps me continue writing and making more videos. Now that we have an idea about what it means to be healthy and what makes us healthy, let's talk about population health. The first definition of population health was published in 1994 in a book called Why Are Some People Healthy and Others Are Not? Of note, these authors are Canadian, and we'll come back to the importance of Canadian authors and how we evolved this definition when we imported it into America. Okay, what does population health really mean? It is the study of why a certain population is healthier than others, determine the risk factors leading to poor health, and to implement policies to mitigate and improve the health of the population. Let's take the example of two populations. In a study of these populations, we find that the first one has higher mortality compared to the second one, which has lower mortality. When studying the risk factors and why this difference in mortality exists, the researchers find that there are fewer parks, walking, and bike lanes, which leads to less exercise in the population that has higher mortality, especially when you compare that to the population with lower mortality. Now, based again on this study, the intervention could be that we build more parks, walking, and bike lanes. Over several decades, as people become more active throughout their lifetime, mortality in both these populations should start becoming equal. This was the original intention and definition of population health by the Canadian authors. Policy interventions at a large population scale to make people healthier. Here in America, we don't trust our government, so when we imported the terminology of population health in 1997, we Americanized it. This American definition was published in a book called Purchasing Population Health. Now, the name of this book should give you an idea of the intent: purchasing and selling the health of a population in a private marketplace. The actual definition is full of economic jargon, but when you translate it into normal language, the new American definition of population health means medical resources are limited, so we need to allocate resources effectively to improve outcomes and reduce costs. So what essentially this definition is saying is that someone needs to ration care as healthcare is expensive. Of course, we cannot say that we are rationing care, so we hide it under the facade of improving outcomes. So let's translate how this economic framework of population health looks like in real life, in a population that had high mortality. Since resources are limited in this example, we have three choices on figuring out how to encourage exercise. The first one is build parks, walking, and bike lanes. The second one, build gyms and give out free memberships. And the third, run an education campaign about the benefits of exercise. The billion-dollar question under population health becomes, who makes these choices? Since our country is in a political stalemate, the health status of people is getting worse every decade, and health costs continue to increase, the academics needed to figure out who is in a position to influence health. And they found the solution in 2003. Since the healthcare system is responsible for rising healthcare costs, the healthcare system should have the responsibility of keeping people healthy. But how could a health system keep a large population healthy? So in order to achieve this objective, the definition of population health was changed again. In this new definition of population health, the word population was replaced by a group of individuals. This allowed health organizations to be held responsible by applying the principles of population health to the smaller group of individuals. Here, the health organization would be responsible for determining why one group is sicker than others, determine the risk factors, and apply intervention to keep people healthy. But when you make someone responsible, you also need a way to measure how they're doing their job. In order to measure if you're doing a job, this definition suggested linking a single health outcome to its health determinant. So for example, mortality, which is a health outcome, could be linked to a lack of exercise, which is a health determinant. This change in the definition of population health allowed the powers to be to create quality metrics that were tied to a single outcome so that they could measure the performance of physicians. Since PCPs are considered the entry into the health system, are responsible for the entire health of the individual, and have a panel of patients, this new definition of population health was applied to your PCP. In practice, this looks like: is there documentation in the medical chart that PCP discussed the role of exercise in keeping you healthy? And did they have this discussion with at least 80% of their panel? Now, I've purposefully taken a ridiculously simple example. And by the way, this quality metric does not exist today. The reason I did this is so that I did not have to get into the medical nuances of quality metrics that we're held accountable for today, and how ridiculous they are once you understand the details. But don't worry, there will be future newsletters and videos on it, so please subscribe if you haven't. Now, let's get back to a story as there's more to it. In 2008, the Institute of Healthcare Improvement published a seminal article in Health Affairs defining the triple aim for health organizations. The goal of this article was to ensure that health organizations are improving the health of the people by providing better care and at a lower cost. Since socioeconomic and environmental factors affect the health of the population, which then leads to higher costs, under triple aim, health organizations became responsible for all the socioeconomic and environmental factors, such as housing, transportation, and access to healthy food. Triple aim therefore cemented the role of population health in the medical system, and a new term, population health management, came into existence. If you know anyone who's been sick and in and out of the hospital in the last couple of years, they were probably assigned a care coordinator. The role of these care coordinators is not only to help people navigate the health system, but also to help with socioeconomic determinants of health. Now, some of you might be wondering, wasn't there something called public health? Wouldn't all this fall under public health? So let's look at the definition of public health from the CDC. It's a huge word salad. But if you take the time to decipher it, this definition is very similar to population health, which is to figure out why populations are unhealthy and to protect their health by taking appropriate action. So some of you might now be scratching your head. What's the difference between public health and population health? They both sound the same. When we talk about public health today, we mean the government. Public health is now predominantly concerned with infectious disease that can spread rapidly in the population, food safety, vaccinations, and a few more things. The term population health is now applied to the health of a group of individuals that is managed by private insurance companies or large health organizations, and increasingly a primary care physician. Anyone who studies healthcare understands that if people don't have access to housing, transportation, food, etc., will eventually use more healthcare resources. And now, under population health, all of this is under the domain of a health organization and your primary care physician. As a country, we have decided not to pay for socioeconomic and environmental health determinants. We have transferred this responsibility to the profit-making medical industrial insurance complex. Let's go back to a population example that had a higher mortality and see how this looks like in this new world. If the government was responsible for population health, they would be building parks, walking and bike lanes. If the insurance companies were involved, they would be building gyms, but more realistically would give out free gym memberships. Those of you who are on silver sneakers, you understand what I'm talking about. And if your PCP is responsible, who has the fewest resources, all we can do is educate people about the benefits of exercise. And since PCPs are held responsible for population health, under this new paradigm, it would be your PCP's responsibility to build the entire infrastructure to take care of socioeconomic and environmental health determinants for the group of individuals, which is the patient panel. And this includes hiring care coordinators, behavioral health, social workers, and also meeting all the quality metrics that are thrown at us. So you can imagine, this laid the foundation to cripple not just primary care in America, but also your health. So hopefully now you understand how over the last couple of decades, the emergence and evolution of population health laid the groundwork to transfer the responsibility of socioeconomic and environmental factors of what makes you healthy to your primary care physician. And this is slowly turning primary care offices into a place where you can get social assistance if you're sick because the government has abandoned you. Now, some of you might be thinking, I have not seen anything like this in my primary care physician's office, and as a patient, this has not affected me. Well, for many of you, this probably has affected you or someone you know, either directly or indirectly. Think about the ability to find a new primary care doctor today or to get an appointment with your primary care doctor today and compare that to 10 to 15 years ago. No one wants to do primary care today because we are being asked to fix what we can't control, and that too without any funding. Several primary care physicians decided to retire or reduce their hours, or they joined large organizations so that these large corporations can fight the large insurance companies against this insanity. Another question some of you might have is, Why can't we just ignore the insurance companies? For that, my friends, you will need to watch my next video on value-based care. These are the contracts that force your primary care physicians to do what the insurance companies tell us to do. You can find a written version with references to the material that I discussed in this video on PCPLens.com. You can also find an audio podcast version of this video on PCPLens.com. If you're watching on YouTube, please like and subscribe. This helps me find a wider audience and spread the message. And if you like this video, please sign up on PCPLens.com so that you don't miss the next episode on value-based care when it's published. Thank you for watching this video, and goodbye.